Next on our agenda, I'd like to talk to or introduce to you Aaron Resnick, who is with the Northwest Healthcare Response Network. And just so everybody knows, the network is really the regional healthcare coalition that serves King and Pierce County. So although they are structured differently, managed differently, they are doing a lot of the same work, and because they really got the jump on a lot of us, they have done a lot of great work in their region that really helps support the work that we're doing, and we learn a lot from a lot of the activities that they do. So Aaron is here representing that healthcare coalition. He joined the network in September 2014. His main responsibilities include overseeing regional healthcare disaster plans and procedures and developing compliance tools for accreditation, licensing, and or regulatory requirements. Previously, he is the Emergency Preparedness Coordinator at Innovac's Fairfax Hospital in Falls Church, Virginia, Northern Virginia's largest hospital and Region Level 1 Trauma and Pediatric Center. Prior work includes foreign and security policy analysis in Washington, D.C., and he's here to tell us the lessons learned from the duck crash.
Okay, can you all hear me okay? Excellent, okay. Thank you, thanks Ed, and thanks very much to Travis and the team for inviting me to be here today and to present. It's a real pleasure and a real honor for me to be here with my peers talking about, unfortunately, what's a pretty sad incident in our neck of the woods in Western Washington. And hopefully my presentation, though, is fitting and good enough for the honor to be invited over here. So feel free to stop me along the way, ask some questions. If I'm saying something that doesn't make sense, if I'm talking too fast, which has been known to happen, if I'm using an acronym that you're not familiar with, I'll try my best not to do that. But feel free to put a hand up or something like that if you aren't following me, aren't tracking, and I'd be happy to stop and explain. As Ed said, as you have on the agenda, my goal today is to walk you through what happened. I'm trying to use the pointer and it's not moving. I'll use that. My goal today is to give you an overview of what happened last fall on September 24th on the Aurora Avenue Bridge, which on a day like today, it's about the same in Seattle, does not look as beautiful as that photo. But to tell you about the crash, about the incident, and walk you through a few key points about our DMCC utilization in King County, about patient tracking, which was a real plus for us, and use of WATrac throughout that process. And as Ed mentioned in the introduction, about lessons learned. And I'll try to spend as much time as I can on all these points, considering how big of an incident it was for us in our region. And I've only been in the region for about a year and a half prior to moving from Washington, D.C. But talking with others and colleagues who have been in the Seattle area for a long time, no one in recent memory can remember an MCI, a mass casualty event, as large and as consequential as this. So this is a real test for us in the greater Puget Sound region. I think we passed that test. Plenty of challenges, plenty of things that we learned and we'll move forward with, and I'm happy to share with you some of those and take any questions and answers as we go. So here we go, away with talking about the collision, what happened. My presentation includes some audio, some video, so I hope we keep you awake so you don't have to hear me the whole time. So we'll start off, the next slide is a little minute and a half or so video from the BBC about the crash, and overhead kind of gives you an idea of what happened, and let me know if you have any questions after that.
A main road in Washington, Seattle, brought to a devastating halt. A bus and an amphibious tour vehicle crashed on the Aurora Bridge. Those on board and nearby described what happened.
We were coming around the curve and he was pointing out the harbor, and next thing I know, I think maybe the traffic slowed down and we veered out of control.
Dozens were taken to hospital.
Injuries range from facial injuries to broken bones to head, so we're in that still evaluation and period.
Around 45 people were on the bus, foreign exchange students and staff from North Seattle College.
At this time, our main focus is to concentrate on the well-being of our students and to notify their families as quickly as possible as we learn information.
90 firefighters were dealing with the aftermath. An investigation will now begin into how the crash happened. Ben Bland, BBC News.
That hopefully gives you a good overview of what it looked like at the scene on the bridge and how many responders. They said the news provider mentioned about 90 providers on the scene, 90 fire and EMS personnel, plus police, plus medical examiner's office, among others. So it was a pretty darn large response that we had in Seattle. What I wanted to do is just give you a little bit of context, a little bit of setting for the crash on that day, on September 24th. So in terms of a location, Seattle's a long and thin city. On both sides, you've got Puget, water on both sides, Puget Sound to the west, Lake Washington to the east, and the bridge, and on a little orange diamond shape, is basically connecting the heart of downtown, central part of the city with the northern part of the city. One of our main arteries. It's State Highway 99 and just immediately west of Interstate 5. So it's one of our key arteries going north and south. And there were, as awful as the crash and the collision was, there were actually some favorable conditions we had that day. Number one was the weather. So unlike what we have outside here, I remember the day very clearly. It was 72 degrees and sunny. So in a sense, for a response where you have patients and victims outside for an extended period of time, it wasn't bad, all things considered. It happened to be a location that was pretty darn good for a situation like this, because just south of the bridge, in more of the central Seattle area, and you'll see another map later, are a lot of concentration of hospitals. So in terms of transport time from the scene to receiving facilities was pretty minimal, which was great. Because it was a bridge and you saw how large of a scene it was a contained scene. There weren't cars and pedestrians and other people going to and from while responders were trying to extricate patients and victims from the charter bus and from the duck vehicle. So it was a nice, safe, contained scene. In terms of resources, interestingly enough, ironically enough, that day and a few days prior, President Xi Jinping of China stopped in the Seattle area on his way to Washington, D.C. and New York. So there was a much higher presence of law enforcement, of fire and EMS in and around the city, which we think contributed to the really terrific response. On the bridge and receiving hospitals, the Seattle Emergency Operations Center, they actually just deactivated that morning from the presidential visit, and of course ramped right back up as soon as we heard about the crash. And the scene you saw with fire and EMS, and you'll hear a little bit more about them later, I'd be remiss if I didn't say that they did a heck of a job on the scene. The Seattle Fire Department did a tremendous job, and I think to the benefit of patients, of victims, and really the whole system that we have in the Seattle area. Good question? Yeah, so Seattle traffic's a little bit tougher than you have right outside of this building. And being near the heart of downtown doesn't make it any easier. So you have the benefit of being near downtown, which is a blessing and a curse, as you're indicating. A couple things happened. Number one, there were listening to audio from the scene of fire, of providers on the scene talking with their dispatch. There was a lot of discussion about closing off access, which way a rig is going to come in from, go to, and what they did is they closed off the southern section of the bridge. So all responders were coming northbound, which meant if you're coming from the south, you'd have to take the 5 or another bridge or a much longer route to get there and enter through the south, enter from the north and enter and exit from the north. So admittedly, I'm not sure how police, who took the lead in traffic control, got cars that were sort of stuck in the accident off of the bridge and away north and south. But in terms of fire setting up the scene, they routed all of their responding traffic to the north side of the bridge and left the south completely blocked. I'll talk a little bit later in terms of lessons learned about rerouting traffic, and it certainly was a concern from the Seattle Department of Transportation's perspective at the EOC. So before mentioning about fire on scene, let me take a step back and tell you my role. Ed gave a nice overview of what I do for the network. My role that day, we have a duty officer system at our coalition. So I happened to be the duty officer that week, which meant I happened to be the liaison down to the Seattle Emergency Operations Center. So I was the one from our coalition that went down to the EOC and represented the healthcare community and represented our coalition with my colleagues down there. So my perspective in coming this afternoon is to give you what I know from the EOC along with our healthcare partner perspective. So speaking of fire, EMS on scene, the next slide is going to be a compilation of audio with some pretty tough photographs from the bridge, from the crash. The audio starts with a 911 call of bystander reporting the crash. It's then followed by an initial dispatch report from the scene, and then a couple conversations between Seattle Fire and our DMCC at Harborview Medical Center in downtown Seattle. Some of the audio, admittedly, maybe a little bit tough to hear. They repeat it, but it's not the details that is important necessarily here. It's giving you a sense of what it was like on the scene, what Harborview, who was hearing it from the fire department colleagues, what they felt like. So.
Seattle Fire Medic 1, what's the address of the problem?
It was on the Aurora Bridge, northbound. There was a head-on accident with one of the ducks, the floating ducks that went across.
Okay. Is anybody trapped that you know of?
Let me run out there. I saw people come fly off the side of it onto the bridge.
There were actually people that were ejected onto the bridge?
Yes.
11:13 hours. MCI response on channel 1. Engine 18, 22, 34, 21, 41, matter 10, 1, battalion 4, 6.
South end of the bridge, we have a quick count, at least 10 patients on the ground. Stand by for a full response. Full. An update, we have at least one confirmed trapped patient. Our accident includes a motor coach and one of the ducks. We have at least 2 red patients at this time, based on on-scene reports, and at least 1 trapped occupants. 3 more patients that look like they're yellow, lying on the ground outside the ducts.
Review?
Yes, this is Medic 1, Doctor.
Hi.
Was someone trying to get a hold of me?
We do have a multiple casualty incident on the Aurora Bridge. We had at least 10 patients ejected from a duck versus a Greyhound bus.
Okay.
So you guys are going to be getting a lot of patients here shortly.
Okay. But do you know trauma versus Medic 1?
Trauma doc for sure. We've got people littered all over the bridge right now.
Oh my goodness. Okay.
Yeah.
Well, I'll just, I've got my pages and my radio. So
okay. Thank you.
Thanks.
Bye-bye.
Harborview DMCC from North Transportation. Harborview, actually now it's Stafford Control Officer, Harborview. Doc, we have 9 red patients coming to you in AMRs and medic units. We are requesting destinations for yellow patients. Good. Are the 9 red patients in route currently? That's affirmative. They are en route. So, in regards to yellow patients, we're going to have them split between Cherry Hill, First Hill, Virginia Mason, and the CU. All of those facilities are aware that they should be expecting 4 to 5 yellow patients. Any yellow use, go to children. Okay, Trauma Doc, I copy you on that we're going to send 3 to 4 patients to each of the hospitals on the Hill and the U. The 3 other hospitals on the Hill as well as the university are have each been told to expect 4 to 5 yellow patients.
So I think hopefully, like I said, maybe a little tough to follow along. I've listened to it enough times where I get what's going on. But hopefully it gives you an idea of to state the obvious, was not your ordinary collision on an ordinary road. And the difficulties and so the heightened sense of anxiety that a lot of people had dealing with this event. Thankfully, as I mentioned, it went really well as an event like this could be in terms of fatalities and injuries affecting dozens of passengers, of tourists. There was a photo towards the end of a group of younger students, and If you don't recall from seeing any media footage, what you had was, as Ed mentioned, you had a ride-the-duck vehicle, a tourist boat, basically a vintage World War II vehicle that was traveling northbound on the bridge. And you had a charter bus of Seattle College international students that were going sightseeing for the day, just right before the semester started, coming southbound. It appeared that the ride-the-duck had an issue, mechanical issue, that led the driver to lose control of the ride-the-duck vehicle, swerving into oncoming traffic on the northbound lane, and as you saw, hitting the charter bus right on the driver's side of the vehicle. There's no barriers, there's no Jersey barriers, anything like that separating north and southbound traffic. There's a lot of questions, concerns following the accident about that, and the bridge specifically considering how narrow things are, how wide the duck vehicle is. Not exactly a high-performance vehicle out there on the road. It wasn't designed exactly to do that. That you saw what happened, and there was in one sense, this is your quote-unquote your typical MCI, things that we plan for, transportation accidents, be it a bus, a plane, a train. Those are sort of our bread and butter, so to speak, from an MCI perspective. But on the other hand, A, we don't have a lot of practice with them, thankfully, and B, there were some unique factors that I'll get into a little bit later that made this particularly challenging and led to some good lessons learned for all of us in the healthcare and the more general responder community. So I want to give you, I'm not going to walk you through every item on the timeline, but I wanted to give you a sense of what was happening when they were happening. I think one of the big takeaways from this is that things happen pretty darn fast. And again, to the credit of particularly of the first responders on scene. It happened to be, I mentioned, good weather, middle of the day, on a weekday, so those contributed to having a lot of people around to help and to do things fairly quick. So just after 11 o'clock in the morning, when the first 911 calls started coming in, the upgrade fire did an initial dispatch of a couple engines, upgraded it within 2 minutes to a mass casualty incident. We're on scene a few minutes later and started radioing back for more resources. 6 minutes after arriving, they were providing notification to our DMCC in King County, and it really was 11 minutes after first arrival that the first patient arrived at Harborview to the level 1 trauma center, which I think is really terrific. And again, it happened to be a good setting, so in another area, even in Seattle or in King County, the times could have been vastly different, but it worked in this case. The Seattle Emergency Operations Center, the last bullet point, was activated about an hour later, which looking back on it seems to be like, oh, gee, that's a really long time. But of course, it takes a while for the process to get going, for people to get notified, to figure out like, yep, this is a little bit different than our daily highway and road crashes. Talking with the fire department afterwards, you saw those images of the tremendous amount of resources they had on the bridge. Seattle, well, certainly they were taxed. There was no indication from the fire department in Seattle that they were overtaxed. They requested additional resources from AMR, BLS units to transport patients. They requested mutual aid from other jurisdictions for medic units, but there was no feeling throughout the city that the rest of the city was being impacted by this event. Not to say that in a different circumstance that 50 or so patient transports wouldn't be a challenge, but in this case, the rest of the city was okay while this event was going on, which I think again is a testament to our first responder system. So looking at a timeline from more of a healthcare perspective and bringing in the coalition, we were notified at about 11:40, and I'll sort of take the initial blame. I was the duty officer that day. I was driving, missed the phone call. So went straight to voicemail from our public health partners. Thankfully, they called a couple of the numbers of the office, so we heard about as timely as they were about what was going on. Not the plan. The plan is ideally for our DMCCs to notify the coalition. It didn't happen in this case, considering often that plans are thrown out the window. As soon as the event happens, we're not complaining. We heard about it from somebody that we're partners with, so that worked for us. We then, as soon as we heard about it, contacted Harborview to figure out what's going on. What are you hearing? What are you thinking? And then we started the process of notifying our 33 hospitals in our 2-county region and other healthcare partners about the event and sending alerts out via WATrac, a system many of you know and use fairly regularly, was our main form of communication with our healthcare partners. And what we use when I start talking about patient tracking, WATrac was the system, and I'll get into a few more details later. We activated our own the HEC right here, our acronym is the Healthcare Emergency Coordinating Center, which is a fancy way of saying our conference room in our office. But that was our center for healthcare coordination in King and Pierce, and we operated out of over the next several days. Just like a city, county, state has their emergency operating center, Seattle USC, where I was for the duration of the initial response, we had our own coordinating center. You mentioned transportation earlier, so again, one of the concerns from a broad emergency management perspective was traffic, particularly as the event progressed and it started getting into evening rush hour. So the bridges opened at about 11:30 that night when the bus and the duck vehicle were removed. I'll get in, again, traffic a little bit later, but while it certainly past the evening rush hour, the city survived while one of its main arteries was closed. I didn't leave the Seattle USC until about 5 o'clock in the morning the next day, Friday the 25th. And so I was there for about 17 hours. I was probably the third to last person to actually leave. And as quickly as things moved from a first responder perspective on the bridge, it didn't feel so quick when you're there for 17 hours. And unfortunately, as fast as first responders can move and as great a job as they did, it's everything else that takes much longer than you wish it really has to. There's things that slow down the process. I'll be the first to admit, and I'll be happy to share those lessons learned, but it definitely does take a toll, and you just wish things could go as fast as a responding unit with lights and sirens at the scene. And even though this accident happened on the 24th of September, it wasn't until Monday, 4 days later, that the City of Seattle and Public Health Seattle and King County fully demobilized and went into a recovery phase. So they really had a pretty large focus on this event for an extended amount of time. So while everything was going on the scene and then moved to healthcare facilities for treatment of patients, of victims, there was about half a dozen or so key activities going on behind the scenes, so to speak, that were equally important once we moved patients and victims off the scene. Of course, treatment at the hospitals. I'll get into specific numbers. Harborview, our level 1 trauma center, they took the bulk of the red tag patients, the critically injured patients. There were other things going on. PIOs, public information, and one of the reasons why I was there for so long at the Seattle USC was the painstaking amount of time and energy expended to figure out who was on the bus and who was on the duck. Unfortunately, in terms of transportation, I feel like the only mode where you really can have a good sense relatively quick is a plane, where you have a manifest of passengers, where you're not backing away out of the jet bridge until the paperwork is done, as we hear from the flight crew, and that just doesn't happen in other modes of transportation. And it took an awfully long time to figure out who was on the bus and who was on the duck, and we still really didn't get it right that first day. Part of the challenges was working with the college, who was not exactly well steeped in emergency management. This is not something that they do, thankfully, on a daily basis, and don't have to do. But this was a bit of a new arena for them, traffic being an issue, and a call center. And I'll go with that. I'll talk about a call center a little bit later when I speak with the role of public health in this. But our public health partners in the county did establish a family notification, reunification call centers, considering where patients were going and how many medical facilities were in play. It helped an awful lot to have a single number that families could call to figure out where their loved ones were, where their friends were. We haven't seen that in other events. I don't think San Bernardino had that in Southern California during the recent mass shooting. So it's a bit of a pride for us to say that it wasn't immediate, and it wasn't automatic, but we did get a call center stood up that I think helped alleviate some concerns about where patients were. Among all these, another item I don't have here on the screen was on top of this, on top of everything, all these activities being coordinated mostly through Seattle EOC and our group at our office in just south of Seattle, there was the political realm. And the mayor's staff was heavily involved in response operations. There was probably at least a half a dozen or so mayoral staff officials in the EOC at any given moment. Total, there's 50 plus people in the EOC. And while we're all busy dealing with many of these activities, you have the added layer of the political dimension. And when the mayor or the mayor's staff, people with titles such as deputy mayor, ask you a question, you respond. And it may be a great question, it may be a less than great question, it may send you on a bit of a wild goose chase away from your immediate mission. it's what happens. And I imagine in any event where that brings in the attention of political leaders, you may have that other dimension. So I learned an awful lot about that and how that dimension works. Okay, oops, I'm sorry, I went ahead. Let me back up. So DMCC, I want to spend a little bit of time on our DMCC at Harborview, what their process is for coordinating and communicating with fire and EMS on scene, with WATrac, getting patients to go to the right place. And I figured instead of me describing it to you, you get to hear from the source. So Ann Newcomb, who's the Director of Emergency Services at Harborview, is the DMCC Director. Our local NBC station did a terrific report with Ann and doing a little retrospective on the crash and how the DMCC works. So you'll get a couple minutes or so on that, and then I've got some specific points to follow up on.
And 3 days after the crash, we're now also getting a clearer picture of how firefighters and paramedics on the bridge worked with doctors and nurses at the hospital. King 5's Dan Casuto has the story from the command center at Harborview.
Minutes after the crash, the firefighters move with a grace, like a symphony responding to a tragedy. From the bridge, before they've even put victims in ambulances, they're already talking to Harborview, alerting them.
They told us that there was a mass casualty, there had been a collision of some sort, and we were to expect a large number of patients.
Ann Newcomb is a nurse at Harborview and also the Director of Emergency Services. She runs the Disaster Medical Response Center, aka this small room next to the ER.
We didn't have lots of details straight away. The details sort of started coming through a few minutes after that.
The details come from the first responders back on the bridge. Even as they work, they radio in a snapshot of the number of patients and their injuries. Back in the command center, Ann Newcomb gets on her computer and radio and alerts the 17 other hospitals. Harborview is in charge of coordinating emergencies like this in King County.
Here, Alpha 1, we have a 0, we have 6, we have blank 9, 2, 5, 10. We have
here
5,
on this 21st century green screen, and as a backup on this 20th century white board, Ann and her team count up all the beds and all the hospitals where they can send victims.
UWMC, Valley Medical Center, Virginia Mason.
They haven't even erased the big white board yet. Look, it still says 12:20 p.m., September 24th.
You can tell 4 beds, 5 beds, 10 beds, so you're just tracking.
That was an hour after the crash.
We train for this, and we spend a lot of time training.
We train for all of these different things that can happen.
Paramedics end up rushing more than 40 victims to hospitals in King County. Less than half of them get rushed to Harborview, the worst of the worst. They're called the Reds, the critical, serious injuries.
The patients walk in right through these doors.
Well, on stretchers.
On stretchers, or the patients get rolled in, I should say.
That's it. Patients roll in this way. We set up triage very quickly. Our staff will decide. We've already got designated spaces for them. So we'll quickly decide which rooms we're going to use to make sure we get the patients in fast.
Fast, efficient, and graceful, even in the face of the gruesome. In Seattle, Dan Casuto, King 5 News.
I don't know if I'd describe it as graceful, as he used, a wonderful term, but it did seem to make things flow a bit more efficiently in patient tracking via WATrac. I'll talk a little bit about that in a second, but thank goodness we have someone like Ann and her staff at our DMCC who did a terrific job with 50 plus transports. We've got a lot of healthcare facilities in the region, but of course, got to make sure they get to the right ones. And we did learn some lessons learned on that. Not all of the patient destinations were perhaps the best decision. And like any healthcare system, the first place patients were transported to were not necessarily the place that they received definitive care, as you can expect in a situation like this. So a little bit more on our DMCC. So again, Harborview, they initially were notified by the police department, which responded within seconds. I think there were, I believe it was a unit associated with the Chinese presidential visit that ended a few hours before, happened to be right nearby. They initially called, and there were further notification by the fire department to Harborview, which was terrific. We as a coalition were able to wonderfully be in constant communication with Harborview and thus with our other healthcare partners about what was going on. We felt like we knew, even though we're 10 miles removed from the event, we felt like we were not necessarily in the middle of it, but had a good idea, good eyes and ears on the scene, and could more readily and more accurately disseminate that information to our healthcare partners, which was great. I want to focus on, for a second here, the approximate number of patients. or I put it approximately 50 patients to 7 hospitals and 1 urgent care center. You'll see some numbers a little bit later, but I cannot tell you with any certainty how many patients were transported. Seattle Fire is not 100% sure. And in terms of WATrac, in terms of patient tracking, it's only as good as what the hospitals reported. So I can show you that number, and I'm happy to do that. But it was, as I mentioned, the political aspect of the crash earlier. One of the questions that we received was, are patient families being notified? Seems like a reasonable question with a relatively straightforward answer. There was discussion at about 10 p.m. that night of, let's get all the hospitals on a call and let's discuss this. Try arranging a conference call with no notice at 10 p.m. at night with hospitals that are pretty darn busy. Was not my suggestion, was not my first choice, and thankfully we didn't go in that direction. The answer, of course, from a hospital perspective is, are you notifying patient families? Was, why does this day different than the other day? Hospitals will notify patients first via, we notify patient families via the patient. If a patient is adult, if a patient is competent and alert and can make decisions on their own, that's going to be left up to the patient to decide. If they're not, if they're a minor, if they're incapacitated, whatever the case may be, that's a different situation. In hospitals, social workers, nursing staff do this every single day. So laying that process to the political side, which is not, not to paint them in a really negative light, but it's a difficult thing to do in the heat of the moment. And I mention it not to call them out because they were really terrific and supportive, but to say that there are other layers of things that could be going on in a future event beyond the actual response and recovery mission. One of the things that really boosted the DMCC presence was having Captain Eric Larson of the Seattle Fire Department on scene at the DMCC. So he arrived about half an hour after the initial 911 calls and helped communicate between the DMCC and on scene in terms of patient distribution, which is really helpful. Whether we would have that capability on a weekend, overnight, unclear, certainly during daylight hours, we think we've got that process set in stone, so to speak, for Seattle Fire to help. So to give you a better idea of locations, I showed you a map earlier of the city and of the bridge. In yellow is the bridge. So many healthcare resources concentrated just south. This radius between Northwest Hospital up in the north and Harborview down here in the south, 4 miles. So very, very quick access to a lot of terrific healthcare facilities. The hospitals in blue, Seattle Children's and Kindred, which is a more long-term acute care facility, they did not, there were no minors, there were no children involved in this crash. There were younger college students, and all of them were over the age of 18. So you have all these locations all right there, so to speak, which was great, because if this happened on the east side or north of Seattle, south of Seattle, I'm not sure the response would have been as coordinated, as fast as we've seen. And to be honest, those of us non-first responders were really playing catch-up, at least in the initial hours of trying to figure out what has happened. Oh, the patients are already at the hospital. Okay, let's catch up as best as we can. So actual numbers, I mentioned sort of the disparity, and you can look at that on several ways. On the left is what the Seattle Emergency Operations Center reported. On the right are what the hospitals reported. In the total at the bottom, you see 61 versus 59. Not bad, admittedly, all things considered. I'd look at the unknowns, the 16 and then 0. So among others, I think there's very few columns that actually align, if any. So what we can say, though, is the general trends. And I think that we can harp on specific numbers and why is 169 and why 61 and why is 159. What's more important is to the right patient get to the right facility. We think 99% of that, the answer is absolutely Harborview. By being level 1, took in the bulk, took in the red tag patients. A few other non-trauma centers did take in, I believe Virginia Mason took in one of their patients, one of their 5, not 2, one of their 5, was a red tag patient, eventually transferred to Harborview. The one question I would say among this chart that we have is group health. Group health in Seattle is an urgent care center, and EMS did transport a patient to group health. Looking back from a DMCC perspective, that probably was an error. It was not a red tag patient. I believe it was a yellow tag patient. Eventually, again, transported to Harborview. But in terms of movement, we did 99% very well. Probably shouldn't have engaged an urgent care center unless every ED in a reasonable area was overflowing and couldn't actually handle the patient. And of course, when being the liaison of the EOC, being asked the question, oh, are all the patients at a hospital, at the hospital? My answer is a little bit, I kind of had to hedge my bets a little bit, because the answer is, well, I can tell you what is being reported from the hospital, which may or may not be the same thing, or all the patients at the hospital. So it's critical that in any of this situation that, that A, the hospitals are reporting accurately, and B, you can just rely on the numbers that you have, and hopefully they're accurate, and you could reconcile anything along the way. So patient tracking. I mentioned that this was one of our key activities, and I want to talk to you a little bit about what happened, how it went, what we learned from. It was a net positive with some growing pains along the way. So we used WATrac to do it for the most part. But what's critical to emphasize about WATrac, whether you know what it is or you don't, is that it is not a panacea. It is not patient tracking. It's a tool that we use to do patient tracking. But it's only as good as someone using it. It's a great tool if used properly, just like a cell phone. If you don't have reception on your cell phone, then you're carrying around a small little brick. So in WATrac, to some extent, is like that. If it's used well, fantastic, and we're running on all cylinders. Early on, and I'll give a lot of credit to the EOC response team, they recognize that once victims have been moved from the scene to hospitals, the investigation was going on, but the immediate life-saving stuff from the bridge perspective had ended. Now we need to figure out where they're going, and are people notifying family members of the from the bridge, and what about family members of living victims? These are international students, role of the State Department and consulates. So you've got a complicated picture that is being painted here. So it became priority number one from the EOC to figure out patient tracking and where patients went, which is wonderful from a healthcare perspective. But with being number one carries the burden of being number one, and I felt, at least as being a liaison there, that all eyes were on the healthcare community and me, since I was that healthcare person there to make sure we're getting it done fast. And of course, the mayor's office wanted information about where patients were going. Problem being is that, as great as WATrac ended up being, we haven't really tested it in this scenario. It's been, to our knowledge, statewide, and feel free to anyone to correct me, it's been used once prior to this event at a nice, beautiful U.S. Open golf tournament. So over 4 days of the U.S. Open, a known event with people literally walking. I mean, it's golf, so no one's even running. Pierce County, just in the Tacoma area, tested it out during the U.S. Open. It seemed to work well, great. We had a nice plan to do some training, finalize the plan for patient tracking, and then we'd be ready to use it in the real world. And of course, that didn't happen, and life doesn't generally work out that way. So we had to use it in real time, and it worked well, again, with some hiccups. Big concern, second to the bottom bullet, was, well, who can see this information? Because you're inputting patient names and some other demographic data, if you have it, their age, perhaps a condition, a triage level, and any other information. So you can paint the scene where I'm at the EOC, there's a whole lot of people interested in this information. I'm walking around with my laptop, and I'm the one person who could see this information. Sounds great, right? Until you have everybody breathing down your neck saying like, So I could see it. My colleagues back in our healthcare emergency coordinating center could see it. The health department could see it. That's it. And that's not the best way to do business. So we're still trying to figure out how to do that. And we'll get into those lessons learned later. Thankfully, at least on the positive side, the public health, since they had access, the information they were providing on the phone to callers about where patients were was via WATrac. What they would say is, if you're calling for Mrs. Smith, well, we have, it looks like Mrs. Smith is at that Swedish First Hill. Here's the number. Please call to verify. So at least could provide that information. So a little bit more just on timing again. The coalition, sent out an alert right after noon to hospitals in our region, regions 5 and 6, King and Pierce County. It took a little while, but about an hour and a half later, we did initiate patient tracking, and it worked in 2 ways. The hospitals that were more adept at this and understood a little better how to use it, they would put information directly into WATrac. We would see it pop up in real time. Those hospitals that needed a little more coaching, a little more help, which is completely fine, they would phone it in manually, and they would call our healthcare emergency coordinating center and say, we have 4 patients, 1 green, 1 red, 1 this. Here are the names, and then my colleagues would manually put that information in. So it took a little bit longer. And on top of that, I mentioned the international component. So a lot of students were from East Asia and South Korea specifically, and trying to figure out whether a name is a first name, a last name. How exactly do you spell Rong? And you know, is with an X, with a C, is with an H. As far as I know, we didn't run into any difficulties with that, but A, I'm sure there were, and I'm just not aware of it, and B, it did add time to and another layer to the complexity of this. And then a question of how long, you know, you have the crash, you have the incident, how long do you have WATrac going for? You know, is it just their initial destination, or is it definitive treatment? We had to go into October 9th, which we acknowledge is probably a little bit too long. But where's that happy medium where you said, okay, we're done tracking, we're done asking, we're done reminding. I don't have a good answer in terms of left third other than October 9th was probably too long, but that's something that each individual coalition, DMCC, would have to figure out, I think, during the event and in the recovery phase of the event. So our response as a coalition, I mentioned to you a few things that we've done, and just want to touch upon them and perhaps summarize them. Of course, we had a liaison at the Seattle EOC. Once I was crashed out of being there for so long, two colleagues jumped in the next morning, Friday, so we didn't miss the beat by having a presence there. We were thankfully in great communication with our healthcare partners, and we would send out situational updates as we were getting information. And of course, WATrac and patient tracking. I think I might have skipped over it on a slide, but one of the real great benefits from a coalition perspective, and we couldn't have guessed it beforehand, was we have an 800 megahertz radio at our office to listen to fire and EMS on scene. Normally, the preference for Seattle Fire is to use a cell phone to communicate with the DMCC. For reasons that I'm not quite sure, they went with radio. So we could literally hear them communicate with the DMCC in real time, which was great. So A, it meant we didn't have to bother Harborview as often, and B, we knew without having to ask and playing a game of telephone what was going on, assuming we could hear and understand and translate radio jargon. So it was a nice benefit to us. A little bit more, one item, and I'll touch upon it again in the lessons learned, is that we, in terms of our priorities of who we're trying to work with and get information from and make sure that they're being taken care of and okay, is the blood centers. And the blood centers should have been a little bit higher up our to-do list. Considering this is a trauma event, mass casualty trauma event, I wouldn't necessarily put them as number one, but pretty darn high on the priority list of calling, in our case, BloodWorks Northwest, and saying, are you okay? Do you need to move any blood products around? Can you actually get them moved? Do you need any help with roadblocks or whatever the case may be? They were fine. They were great. They did move things around. There were some social media rumors about needing help with a blood drive and those sorts of things. Actually, thankfully, in our community, people came out in droves to donate blood after this event. So we didn't have any issue post-event with blood supply, but it is something that we need more of a trigger for us to think, let's call the blood center as soon as we're aware of what's going on. Like the Seattle EOC, our own healthcare center was open for several days, day shift, and then we switched to the duty officer line overnight, and we demobilized that Friday night. We did participate in recovery conference calls after the event. The Seattle EOC, several days post-event, transferred long-term case management to the Salvation Army, and they had conference calls throughout that process, setting up the process and making sure that patients and victims and their families were taken care of and things weren't falling through the cracks as family members were flying in from abroad and arranging transport for the deceased and remains and those sorts of issues. So we participated in conference calls, but it passed more to a recovery phase that wasn't really within our bandwidth. So public health, I touched on a little bit about what public health did. They were down at the Seattle EOC with me as well, and we have a great working relationship with them, which really paid dividends during this. Their main, at least initial role, was the call center, as I mentioned. So at about 1:30 in the afternoon, they made an offer to the healthcare community to stand up the call center. We discussed it internally. We talked to Harborview. We talked to a few other healthcare partners. Would this be useful? What do you want? It took us a little bit. By about 2 o'clock, we hit the go button on it, and it was stood up using the help of the 211 system and operators and call takers, and helped a little bit alleviate the number of calls the healthcare system were receiving in the Seattle area. And again, as I mentioned before, their information was relied on WATrac, which was provided by the hospitals in terms of patient notification and family reunification. Call center was open 24/7 for a few days, and was certainly a big help. I think there is a lesson learned on this, and I'll touch that a little bit later, about indicators and triggers for a call center. It's not a switch you can flip, and all of a sudden you've got 10 operators and standing by to take your call. You got to get the phone number out there, and you have to make sure that whatever you put out there initially, that doesn't change because you do want it open 24/7, that sort of thing. So there's a lot of give and take to actually get that process stood up. And because we haven't used it that often, we haven't practiced that often, there were a few growing pains throughout the process. The lessons learned. There is a lot. A few of them are even positive. So on the positive side of the ledger, the DOC did a really great job notifying partners early on what was happening. We based on an alert, they followed up with a call to us, among other partners. We got down there, which is great. So that process, that communication coordination worked really well. Patient tracking, as difficult it was to stand up and a little bit of trial and error, and we hadn't really practiced it, it worked, and it worked really well. And I think it set, for us in Western Washington, set the standard about where we're going to in future events. And the expectation is that WATrac will be there immediately, like it or not. But it did work in this case, which we're all really proud of in our region. Our coordination with healthcare was great. Thankfully, phone lines were still up, so we didn't have to deal with going to radio communication or satellite phone or any type of backup communication. So we were able to not have any issues communicating with the hospitals about what was going on. Law enforcement and other agencies were pretty key in terms of family reunification process, and they were great partners. We didn't have all that well-established relationships with them prior to, but it was really gratifying to work with senior reps from Seattle Police and other city agencies on the family reunification piece. And I think we as a coalition, I'll pat ourselves on the back, admittedly, but I think we did about as well as we could considering the circumstances and considering the complexities, and we haven't had a lot of MCI, thankfully, to deal with. But I think we as a coalition proved our worth to our partners. Some partners, of course, I'm sure you share this, don't know exactly what a coalition is and who do you represent and who do you work for. So that helped the education piece along an awful lot that day, the following days, and I think it really contributed to a more robust system. So on the more challenging side of the ledger in terms of our lessons learned, so as great as I think patient tracking went, it shouldn't have taken as long as it did. I shouldn't have been there for 17 hours, and one of the reasons why it took so long is at some point, me and a couple of colleagues at the EOC sort of gave up on the phone calls and electronic system and just drove over to Harborview, all of like 5 blocks away from us, and went and talked to one of their emergency department social workers and went through their electronic system. And that paid humongous dividends and was really, really helpful, considering we couldn't get a list from the college of who was on the bus to match that up necessarily with the victims. The manifest from the Ride the Duck, they gave us a list of those who had purchased tickets. That doesn't mean they were actually on the vehicle. So we were really kind of shooting in the dark, so to speak, about who was there, who was not, what were we looking at. So it took much longer than I think it should, and certainly from a go perspective, what you feel like it should go. As I mentioned in terms of numbers, we just don't know the final numbers. We're okay, as a healthcare community, we're okay with that, but it does make you wonder about that Fire was reporting one numbers, which EOC was then reporting, WATrac had another numbers, and it's just complicated because you also have the situation where victims on scene who were treated and released on the scene, several of those started to trickle in the hours and days later. So are hospital staff asking them, were you part of the incident? Are they documenting that? So if not, then it's never going to be reported. So considering if you scale up this event, take the Paris attacks, to try to figure out a number from an event of that size, of that magnitude, is a yeoman's work. I don't think really anybody has the capacity to do 100% accurately. Call centers, we got them stood up. It took too long. My feeling is there should be some sort of indicator that if it's an MCI event per fire department protocols, then at least the process for getting the call center started should begin. The way it worked in this event, we had the discussion. Should we? Shouldn't we? Yeah. Okay. Let's do it. I think we can get rid of some of that back and forth initial conversation to at least get the process started, and then you stand down if it's not warranted. HIPAA, large concern, of course. Who can see the information? Everybody wanted it. At one point, I I had a gentleman come over to me in the OC. He's like, I need to see the list. I'm like, and you are? And he's like, Seattle Police Department Legal Counsel. Here you go. So here's my laptop. Let's turn around. Let's go over this. But it shouldn't sort of take this like, who are you? Am I going to get in trouble? That sort of thing. So we all could use, we all being in Seattle, we all could use more education on HIPAA and who we could share things with. We as a coalition were pretty darn conservative on this, and mostly because we hadn't used patient tracking before in a real live event, and the last thing we want to do is sort of overshare and deal with liability issues on the back end. So we've got some education to do on that moving forward. I mentioned considering the needs a little quicker at the blood center. We did consider our needs. I would just do it a little bit quicker. And then the last one, the multiple requests to healthcare. That the hospitals felt they were being bombarded, not just by calls of people looking for victims and patients, but by city and responder and government agencies asking the same question by 10 different people at 10 different times. And so what's the remedy for that? I think the answer to some extent is better coordination at the EOC level to streamline requests. Needs to start there. And then do you have a funnel for healthcare? Is it a coalition? Does the coalition become the repository for requests and information for healthcare? Maybe yes, maybe no. There's probably going to be good reasons for why a detective, why a so-and-so from a city or county or state agency needs to directly contact the hospital. We don't want to stop that process, but it does speak to the need of a process for consolidating requests so healthcare can actually take care of patients and not answer the phone every 5 minutes. I want to go back up because I skipped over the international component. Everyone involved from the college side was an international student, and many of the passengers on the duck were international tourists. So you've got that component, so a family notification component, no real support network in the city, in the region, and of course language barriers, language and cultural barriers, I should say. And I mentioned cultural along with language because that became an issue in terms of some of the death notifications and who is going to do the notification, how it's going to be done. Is a family member on the other end of the phone line going to believe the caller when they're actually making that notification? It's a tough thing to watch, and issues that many of us have never thought of before. But that added to the complexity when you have consulates, well-meaning governmental consulates, wanting to know where victims were taken to, where are their foreign nationals. And they say, well, you've got 3 Chinese nationals here, 3 South Koreans there. They're like, wait a minute, maybe the patients don't want their government to know where they are. So not everyone is a fire-breathing patriot of the countries that they came from. So that issue factors into it as well. So a lot of complexity. In general went well, but a lot of lessons learned. More broadly, and I'm wrapping up in a minute. More broadly, in terms of lessons learned, were the transportation piece we talked about before. Thankfully, there are other bridges in Seattle. A lot of them go up and down for boat traffic, and there was a nice workaround with the Coast Guard to make sure the other bridges stayed down during the duration of the duck and the bus were on the bridge to alleviate some of the traffic concern. But what do you actually do with the vehicles? Have you thought about that before? I certainly haven't. Since the National Transportation Safety Board came to town, you need to take the vehicles to a place so they can be stored safely with 24/7 security camera footage and a locked facility for the NTSB to do their job afterwards. Not everybody has that warehouse just waiting for something the size of a bus and a duck to go over. So it took a little bit between Department of Transportation and the police department to figure out where they're going to go once they're on a flatbed tow truck. Property. So there are processes in place day to day of what to do with property at a healthcare facility, from police department, for investigation, that sort of thing. We didn't seem to have the best process in Seattle. There are phone calls over the weekend of who should take the lead once PD released property. Should the hospitals deal with that? No, probably not the best spot. So eventually it was sorted out through a family center, but it did speak to the need for a better process in our region about how to communicate that property is ready to go back. Here's where to find it. Here's where the location is. I mentioned political leaders before. I don't want to dwell on that too much, but it did add yet another layer of complexity, and I think took some time and some eyes off the ball for us. The NTSB, I'd say, they were a pleasure to work with when they were there. They did want to speak with victims and go to hospitals, but what would have been helpful from that perspective is they were flying in from the Washington, D.C. area. It would have been nice to know prior to them arriving what they wanted and where they wanted to go and wanted to see and talk to. Not necessarily in order. We didn't need an agenda, but assuming that other accidents are similar in terms of what they're looking at, it'd be nice to know from them what their expectations are and what we on the ground should prepare for their arrival. So I think that's something that we all can work through our local emergency management agencies, perhaps into the state, to ask that question. Is there a generic kind of cheat sheet, a job action sheet, so to speak, that we can pull out? If the NTSB says they're coming, that we know what we have to be prepared for in terms of their arrival. So next steps, there's two big after-action reports being written, one by the city, one by the healthcare community in coordination with public health. The really big to-dos from a healthcare perspective are WATrac roles and responsibilities, who gets to see the data and who doesn't, HIPAA, of course, along the same line, and coordination in terms of communication with healthcare and how requests for information are going to be funneled, if that's the right way to do it. And engaging with other key healthcare personnel. Our bread and butter for our coalition are the emergency managers at the hospital, who've been a pleasure to work with over the years. In this situation, that one sort of point of contact wasn't enough and wasn't necessarily the best at each facility. We engaged social workers for the first time, and it worked out well. They know their patients. So in terms of asking the questions about have family members notified, ask a social worker. They know how this process works. They were wonderful to work with, and I think speaks to having a deeper bench, so to speak, of people you can go to at a healthcare facility. I'll stop there. I know that was a lot. I went over time, and I apologize for that. So are there any questions about anything that I mentioned? Yeah. Thank you. There was, and I glossed over that. That was my fault. So public health did open up a family assistance center. So for issues, and perhaps I'm sure you're thinking of them, hotels for family members coming in, flights, cell phones, glasses that were lost at the scene, eyeglasses at the scene. Public health did open a family assistance center at our convention center, so a central point downtown. We did have some nice donations from the community to help alleviate some of the costs and some of the issues for that. Public health, through their health and medical area command, took that. So that wasn't a central event via the Emergency Operations Center. Public health took that sort of offline, for lack of a better term, and did that within their own agency. But once the call center was stood up that evening, I think it was up by, the Family Assistance Center was up by Saturday, perhaps even earlier, so at maximum 2 days, but it might have been one day post. And they dealt with travel arrangements for families and hotels and those sorts of issues. Anybody else? Sorry. Yes, and so, oh, I'm sorry. Repeating the question was regarding HIPAA and being in a disaster, crisis care. Is HIPAA applicable in this situation? So this was not, for us, this was not a situation where crisis standards of care were initiated. So we are still dealing with the regular rules of the road, so to speak. I agree with you that HIPAA should never be a crutch. I think, unfortunately, it's easy to say, harder to do. And in our case, we did treat it more as a crutch than an opportunity. That said, we know law enforcement, of course, can see patient information because it's part of the investigation. We know public health can. We know healthcare can see it. The question really was more that the Office of Intergovernmental Relations wanted to see the list. Consulates were interested in the list. All with good intentions, because they all wanted to make sure that their people were safe and taken care of. Great. But that's not the way it works in the healthcare community. And just because you're calling a hospital and saying, I'm Detective so-and-so, that doesn't mean that the hospital is all of a sudden ready to just divulge information. That happened several times where we the coalition, received phone calls saying, we've gotten calls from so-and-so. Does this make any sense? And thankfully, they have that suspicion. To your point, though, the answer, I think a lot of people look at it, oh, gee, we need to expand access to who can see WATrac, who can see patient tracking information. We as a coalition don't see it that way. We have a process in place. It's more an education and training of our city and county colleagues to say, Department of Transportation, you're in charge of transportation. Coalition, you've got patient tracking. As long as we can share the information with the right people, then I think we'll have a successful process. And I think it's more ensuring that those that aren't privy and can't be privy to this information aren't breathing down our necks, sitting next to us. So to your point, I think it's more of an educational piece to make sure the right people are aware of what we can and can't share, and that yes, we need to do a better job of sharing what we can as quickly as possible, but also putting on the brakes where it needs to be put. Any other questions? Sir. So they, in this case, they weren't, unlike day-to-day operations. Maybe this is actually an example of where it wasn't a day-to-day operation. Oh, sorry, thank you. The question was, could EMS units on scene provide any patient information and perhaps help the patient tracking process? Is that right, Bill? Like, okay. So in this case, unlike day-to-day, they were not providing a full report to the hospitals. You know, a 18-year-old male left. It was more of a situation where which hospitals could take red, yellow, green tag patients. Okay, these hospitals can. Then, as you hopefully heard from the audio, then minus Harborview, these hospitals should be prepared to take roughly 5 to 6 yellow tag patients. If we can tell you who you're going to get, great. If not, just be ready to accept them when they come. We'll at least tell you when they've left the scene. So the best that fire and EMS could do in this situation was simply make the call to the DMCC, who would then call the hospital saying, ambulance 01 is on its way to Swedish Cherry Hill with yellow tag patients. If they could give a gender and maybe a general age, great, but they couldn't. They didn't have the time to be able to provide much more demographic information. So in this situation, an MCI like this, we weren't able to get much from the scene, and I don't fault first responders at all for that. Anything else? All right. Well, again, thank you very much. Be happy. I'll be here throughout the whole meeting. So if you have any questions that come up on the way, I'd be happy to answer any. Thank you.